Thank you very much. Thank you very much, Katerina, and all of you for the invitation. I'm really happy to be here. And I'm going to talk about lung cancer screening in Greece. Well, the title is Novel Insights. I'm not sure I can give you many, but okay. So, the lung cancer problem is a huge one. In Europe, there are about 1,000 premature deaths per day. So that's equal to 2 jumbo jets crashing on a daily basis. It is a huge problem. And if we look at data from Greece, then we had almost 9,000 new cases in 2020, and this is estimated to rise up to 11,000 by 2040. And as far as deaths go, we had almost more than 7,500 deaths in 2020, and it is estimated that this will go almost to 10,000 deaths. So almost everybody with lung cancer in Greece dies, and there are lots of cases. So we need to prevent the epidemic, not just in Greece, but worldwide. And what do we do? First of all, we have primary prevention, which is avoidance of risk factors, of which smoking is, of course, the biggest one, although there are others. Secondary prevention, which is early diagnosis at a stage when the disease is curable. And finally, tertiary prevention, which is about treatment, correct treatment. And I'm not going to go into that at all. Primary prevention, what do we need? Mainly stopping smoking completely, globally. In Greece, of course, and I'll show you some more data, it is the main factor. I mean, we do have asbestos that is linked to malignancy, we do have radon, but most of the cases are actually linked to smoking. So once we've dealt with that, and I'll go back to smoking, we have to deal with secondary prevention. And secondary prevention means screening. And we've introduced in Greece a lot of screening lately. But there are a few things we need to remember. Screening is not a once-off test. It is a repeated procedure that causes a lot of stress for the patient and the family. And you cannot run it on everyone. You have to define the population that really benefits and makes the whole exercise valid and cost-effective. So first of all, we have to define the population that will undergo screening. Then we have to decide on the screening intervals. We can't have a low-dose CT every month. We have to choose whether it's yearly or every 2 years. Then we have to have the protocol of testing. Is it a low-dose CT scan? Is it inhaled markers? What should we do? And finally, whatever we choose, we should keep testing that this is the correct procedure. This is the right way to go. We have the right guidelines. We have the right centers. We have the right people. And just to show you what the outcome is of lung cancer screening, if we do it through a lung cancer screening program, most of the patients, and I'll show you different data, are diagnosed at stage 1 or 2, early stage. If we do it through a lung cancer screening program outside the lung cancer screening program, most of the patients will come at stage 3 or 4. So by the time symptoms appear, it's quite late to do curative treatment. So, and Joanna will talk to you about the current landscape in Europe. I'm just showing you this. There have been a number of studies in Europe and the US. The two biggest ones are the NLST in the States and the Nelson study in Europe, which is probably the best by far. It ran for 10 years. And now after this, we know that what we can do is the best ages to choose are between 55 and 75 years of age, smokers with a history of 25 years, or even ex-smokers who have quit smoking less than 15 years ago. And the interval can be up to 2 years from one CT to the other, assuming that the first one was without any findings. So there are problems with lung cancer screening. One is cost, which makes it difficult to be accepted by most governments across Europe and the world. But there have been a number of studies showing that it is cost effective, so cost is not an issue, especially not in our country, where we do about as many CT scans per year as does Germany, with 8 times our population. So we do the CT scans, we just have no program to enter them and get the data out and have really good results. And the second one is false positives. And I'm showing you this study, those false positives from the NLST, where in the first reading it was up to 26% false positive. It's huge because patients undergo stress, they undergo procedures which they should not undergo. They did a retrospective study using Landgraf criteria, and the false positives were about 13%. While in the Nelson study, and I remind you that the Nelson study ran in expert centers, false positives were only 3.6%. And that shows you that it is centers with high output and experience that should do screening studies. Not everyone, not every radiologist, not every pulmonologist. It should be experts who do screening studies. Okay, and this is the SOLA study, and again, Joanna will talk to you more about it. It is a pan-European study aiming at sort of women, which were less included in the Nelson study, aiming at far-to-reach populations, which also don't have medical tests often and are, they don't approach the doctors. It runs in 15 countries and 33 centers. So the aim is to approach women, to approach difficult to reach, hard to reach populations and high risk people. This is the Greek team. It ran in Athens at the Athens Chest Hospital, Sotiria, and here at Pagny. And there were inclusion and exclusion criteria. Inclusion criteria in our center, because Greece has a high number of smokers, we chose to do 50 to 75-year-olds with a history of more than 25 years and smokers who had quit less than 15 years ago. Exclusion criteria were current infection, symptoms suggestive of lung cancer already, or a history of cancer. And we were supposed to have 3 appointments, one an initial appointment, then a second appointment where patients had more questionnaires and signed, and a third appointment. But actually, because we were aiming, and this is our brochure, we were aiming at hard-to-reach populations, and we did not have mobile units in Greece, so people had to come to us. We realized very early on that it was impossible to bring them to us 3 times. So we combined the first and second appointment into one, ran all the tests, all the questionnaires, spirometries, whatever, in the first, and explained the whole process in the first run. We talked about smoking and smoking cessation, although we did not offer a program within the lung cancer screening. And then we had the second test. And it was difficult because to get to hard-to-reach population, especially the Roma population, we had to go and meet with social workers in every council, city council where the population lived. And it was a nightmare. We had to organize minibuses to get them to the hospital. It was not an easy access. So this is what we did, 2 appointments. And these are the results we have so far. And this is where we're going to stop, actually, 509 participants. Maybe they will go to 100 to 510 or something. Hard to reach, out of them were about half, so 239, 136 men, 374 women. We had 448 active smokers, which is probably the highest in Europe. And ex-smokers were 12%. And all the studies so far that I've seen, the active smokers are less than 50%. And Joanna will show us more data. But this is quite disheartening for this country. I mean, we still smoke a lot. Our findings, 7 positive, confirmed by histology, 67 indeterminate who are being closely followed up, and some will have procedures, and 435 negative. In our population, 7 people had, as I said, positive CT findings, and 67 had suspicious findings, but because we had a lot of socially deprived population, in our hands, 2 already had 3A stage lung cancer. So we did not get, we had 2 with 1A, and the rest was in between. But because this is a socially deprived population, lung cancer was diagnosed already quite advanced. This is, of course, a first round. If you enter this population into a continuous testing, then you will eventually get lung cancers diagnosed at an early stage. These are just some of the findings, and you can see here, I'm not sure I can. So the second one has nodes, and you can see them. We also had a lot of incidental findings, coronary artery calcifications up to half the population, and many of them were young, emphysema, bronchiectasis, and osteoporosis. But we also had some quite strange findings. We had DLD, of course. We had one case of histiocytosis, TB, an adrenal tumor, a pancreatic cancer, and a schwannoma. So just to show you the cardiovascular disease classification, in yellow is the severe, and in gray is medium severity. And this is osteoporosis and bronchiectasis. So screening works. It has been shown to work. An early stage diagnosis is possible, but we need to have further actions, especially in hard to reach population. And in Greece, as I said, more than 80% of participants were active smokers. So one way to go around the problem is when you include patients in a lung cancer screening program, you should also offer smoking cessation treatment already there, organized within the center, not send the patients elsewhere and sort of ask them to book appointments, but have everything ready for them. And this has been shown to work, although the data still need a lot of, in order to make it more effective, we have to work a lot on that. So a smoking cessation intervention alongside screening improved cost effectiveness and was successful in a minority of patients, I will say. But which intervention is best, we don't yet know. Probably gradual reduction plus behavioral treatment is the best way to go. And it is labor intensive for the personnel of the hospitals. So we need to prevent the epidemic, first of all. And the first thing is we should not allow people to start smoking. And of course, we know that smoking is a risk factor since the 60s, the 1960s. This is a photograph, and I need you to see this, is from 1994, and there are 7 CEOs of the tobacco industry swearing under oath at the US Senate that nicotine is not addictive. I mean, you can laugh, but this is what happened, and this is 30 years ago. And also, we have new ways of introducing people to smoking. This is Yule, which has used media influencers to lure young people into this type of smoking. And there's the CEO of the company saying, I hope there was nothing that we did that made it appealing to them. Well, okay, you can. It's just, so smoking cessation interventions in the lung cancer screening setting, there's the scale study. I think this is what this country should focus on. 2 things. Screening centers that have a high output and high expertise, and smoking cessation programs. And we have to work with the lawmakers to make sure that the laws are actually effective and not have lawmakers saying, well, it's okay if you smoke in bouzoukia, or it's okay if you smoke in bars. It's not okay. So how can we cope with a cancer pandemic? First of all, prevention, then early diagnosis through screening. And here we can organize it, even if the state doesn't, within the hospital, we can organize it because we can still get away with prescribing CT scans. We just have to organize the whole program so that we get something out of it and people get something out of it. Multidisciplinary care and dedicated organ-specific tumor boards are also extremely important. Access to medications, which at least here we have, and all treatment modalities. And we do still have problems with radiotherapy, but at least it's getting better. And we need to make sure that we review continuously what we do and correct our mistakes. See the literature all the time, see our results, and correct. These are it's old, we have a new one as well, but we have to do accredited centers, full MDT care, longitudinal follow-up, also true. We don't have to enter a person once and then forget about the person. The inclusion criteria I've already talked, and it is important to have algorithms and appraisal criteria to make sure that the program runs smoothly and is effective. There are other things we can do, like understanding whether there are other ways, like blood or inhalation markers. And definitely we're not there yet. Maybe we will be in the future, but at the time, LDCT is the gold standard for. We have to also have very strict guidelines on how to cope with the findings, whether they're nodules or whether they're incidental findings. And again, expertise makes things different. And we also have to always be there for our patients. Thank you very much.